everyone. This is Caleb from the National Rural Health Resource Center and the task team. We are, we are joined together today to talk about, to initiate our learning collaborative on the transition to value. So thank you for joining us. We might have a couple people joining us late. I know NRHA had a call that was scheduled just before this. All of these webinars will be recorded and posted to the Moodle, the web-based interface that we'll hear more about shortly, just as soon as we're able to. We know we had a pretty quick scheduling and turnaround on this, so we weren't able to poll everyone as much as we would have liked to find the optimal times for these webinars. So we appreciate your flexibility and willingness to participate, even if it's not ideal. I'm happy and pleased to have Maeve McClellan from the National Rural Accountable Care Consortium to kind of host and facilitate this learning collaborative, and she'll tell you more about the agenda and some of the expectations and things like that. But really, we want this to be a nice small group learning collaborative. We want to learn what we don't know. We want to know. We want to expand what we do know. We want to have, questions and open dialogue. And you'll see there in the chat feature that all phones are muted by default. But if you press star to communicate, ask questions, let us know what you're thinking and what we're doing. Today's webinar will do a lot of the housekeeping, the agenda, expectations and timelines, things like that. Philip, our IT web guy from the center, is here to walk us through Moodle and give you a little crash course on that. And then Maeve will get us going and talk a little bit about the value proposition and where things are going and how that's going. Do we have any questions before we get started? Well, not hearing any. I believe logistics, we would go to you, correct, Phil? Unless, Maeve, do you have anything to
let's
start with?
Turn it over. Yeah, let's turn it over to Phil, and after Phil's done, we'll go ahead and jump right into the content.
Sounds great. Thank you.
All right. Well, this is Phil Burke at the National Rural Health Resource Center. I am the IT specialist here, so I will do my best not to bore the group too much. But we do have a website that's put together for the purposes of kind of holding all the course content, and we just wanted to go over those logistics real briefly to give you a feel for where you'll find information related to this course. I'm going to switch to sharing my screen here. So hopefully everyone's seeing my screen. Everybody this morning should have received an email that looks like this. It's just an automated email from our site telling you that you have a new account at the site. I was just noticing somebody, we had the wrong name for someone in our system, so we'll work to correct that, but that might require that I generate a new email, so apologies for that. So this is the email you'll receive. It will give you a username and password, and it gives you a link to the site to log in. So if you click on this link, it will lead you to this page. So this is just a page where you'll need to log in with your username and password just as it was sent to you in the email. So I'll demonstrate that briefly. The username will accept either your username or your email address. Apologies. Okay. Once you log in the first time, the system is going to ask you for that password one more time, and it will require you to create your own new password. And there are some requirements. Just pay attention to these requirements for the passwords. They require at least one number, a lowercase letter, an uppercase letter, and a alphanumeric character. So I will create a new password for myself. I will try that again because I didn't meet my requirements. Apologies again. So that will allow you to log into the site, and all you'll need to do after that is just click this continue button, which will bring you to your dashboard page. The dashboard will allow you to find the course. If you just click on this courses tab in the middle, you'll see the courses that you're enrolled in. So everyone in this group will see this Transition to Value Collaborative course. So if you click on that link, it will bring you to where we have all of the course content. So this is, Maeve will be talking about this shortly, I'm sure, but the first part of the course right now is we're in the what does value-based pay mean for rural, and some of the information related to the courses here, including Maeve's PowerPoint presentation, and then once this webinar is finished, we will also upload a link to the recording so you can come back and see the content of the webinar. I also want to point out that this sidebar is collapsible. The button up at the top left corner will either expand or collapse the sidebar. If you click on the Site Home link on the left side, it will bring you to the home page for the entire site. Basically, everything I'm going over today is documented in our course participant guide, and so all of these links will provide you instructions for everything you'll see me do today. So we've already been through login for the first time. The other thing that we encourage you to do is add a picture to your profile, and the way to do that is just click on your name up at the top right corner, click on Profile, then click the Edit Profile link kind of in the middle of the page. And you can verify that your information is correct here. As we go down to the bottom, there's a new picture area. If you click this blue arrow, it will pop up like this, and I can upload a file, or I will upload a picture of myself. And this is just, it helps make forum posts a little bit more personable because you can see the person who's actually doing the talking. So once you've checked over everything, you can just scroll to the bottom and click Update Profile, and then you'll see your photo show up at the top right of the page. A couple other things to point out. On the forum, or on the course itself, and I'm going to use a different course to demonstrate this, there are two kind of main pieces of content that might not work quite the same as other websites. They're a little bit more interactive. One is the assignment, and we don't have an assignment this week, but I understand that this may be used in future weeks of the course. So here's an example assignment, a pre-course assessment. If I click on this assignment icon on the course page, I get a quick overview of the assignment. So it gives me some instructions. Please download the assessment, fill out the table, and then submit the completed assignment. And it also gives me a Word document, and this is what I download to begin my work. So I'll click on this document, and this downloads to my computer, which I can then open up. And I just need to fill out the table that was included in this Word document. And then I can save my work on my computer. From there, I can go back to the assignment page, and at the bottom of the assignment page, there's a button to add a submission. And I can click on that. And basically the way assignments are set up is you do the work on the file on your own computer, and then you just need to upload that file back to the website. So I'll click on the blue arrow again. This is similar to the interface we used to upload my photo earlier. And I can choose my assignment file. And so here's the file that I completed. And click upload this file. And I can tell it's things went well because I can see my file here in this box after I've done that. And all I need to do to submit the file is click the Save Changes link at the bottom. Once that's done, the pre-course assessment shows up, and I can see that I've submitted assignment for grading. One thing to note is we don't usually assign like grade level grades, A, B, C, or Ds. So because we don't do that, the software we use for the system will basically always show not graded. So don't be concerned about it showing not graded. I can see the file I submitted. So if I were to click on this again, it would download the file for me. And I can also include comments if I'd like to, or I can click the Edit Submission button if I wanted to make a change to the file that I submitted. Stop for just a moment here. Are there any questions so far? All right, not hearing any questions. So the only other piece of information I just really want to show real quickly is the course forum. And this is a functionality that will allow you to have conversations with other participants or the instructor. Forums look like this. There's a little blue and green icon with the forum link next to it. And if you click on this, you'll find that it looks probably similar to a lot of other forum websites you may have seen in the past. You can start a new discussion topic with the button at the top of the forum. The only two fields that are required are the subject and the message. So those are the two fields I've just completed here. If you wanted to, you could add an attachment. So if you had a file that you wanted to share with other people who are participating in the collaborative, you could add that here, just like we added the assignment file earlier. And once you're happy with your message, you can click Post to Forum. And by default, you have 30 minutes to edit your message. After those 30 minutes go by, you won't be able to edit the message anymore, but you could clarify with a reply or something like that. And after 30 minutes, an email notification will go out to everyone who's subscribed to the forum to receive notifications. Those are enabled by default. If you would like to change your subscription settings, you can do that either on a per discussion basis. So For each discussion, on the right-hand side, there's an envelope. Open envelopes mean that you are not subscribed to receive email notifications when people post new content, and closed envelopes like this one indicate that you are subscribed to receive an email notification if someone posts a reply to that discussion. It's also possible to turn off emails from our system entirely. The system will email you notifications if a new assignment is posted or if the instructor provides feedback on an assignment that you submitted. It will also email you just to confirm that you submitted an assignment. So those are just a few of the emails that get sent by the system. For the forum itself, if you wanted to unsubscribe from everything, you can use the subscribe to forum button and then follow that up with unsubscribe from the forum, and it will change all of the posts to unsubscribe.
A real quick note too, while I'm thinking about it and I don't forget, if you have not received an email from Phil welcoming you to the Learning Collaborative and to the Moodle platform, please let me know. We've done our best to try and make sure we have everyone listed and emailed and joined to participate, but you know, sometimes I only have one or two contacts per state. So if you do not have access to this yet, please send me an email and let me know, and we'll get you started. Sorry.
Oh, no problem. That really covers the basic functionality of using the forum and using assignments. The only other thing I'll point out is there's always a quick path back to your courses. If you click on the Learning Communities link at the top left of the screen, you'll see your courses on the dashboard page that leads you to. So from here I can click Transition to Value Collaborative, and that will show me all of the information for the course. And we can see that this is the first week's content. As additional weeks go by, new content will become available on this page. So yeah, any further questions about the functionality of the website that we have?
Again, *2 will unmute your line.
Well, if there are no questions, feel free to reach out. If you do need help with the website in any way, you can reach me at it@ruralcenter.org. That email address is also included in our guide. If you go to the top of the login for the first time page, you can see the it@ruralcenter.org email address. And I'm sure Caleb is also able to hunt me down. He knows where I live. So
Absolutely.
Thanks, everyone.
I'll give you a cell phone number if you need it. Well, thank you, Phil. So yeah, as you guys go in there and wander around a little bit and develop questions, please let us know. But we wanted to at least give you a little intro. Before we kick it off with Maeve, if we don't have any questions, we have a couple questions for you guys to just get some initial baseline information about how you rate your initial feelings and comfort level and knowledge with alternative payment models and the transition to value. So just take a second and click a button for me, and we'll see if we can't change these somewhat unknowledgeable to very knowledgeable in the next couple weeks. Catherine. Yeah, we'll get to the tabulated responses in just a second. I think once we kind of close the poll, then it shows that. Is that correct, Shannon? All right. Are we able to, does that display as a graph, Shannon?
I will check just a second here. No, I don't believe that it does. That's something that I could certainly tabulate, though, and put on Moodle for everybody.
Okay. Yeah, that'd be great if we can do that.
No problem.
All righty. Well, thank you for taking the time for that, guys, and we will see what we can do to move those numbers to totally comfortable. And as we're loading some of Maeve's presentation here, we'll get started.
All right. It looks like the screen is up for me, and hopefully everybody else can see it now, but I'm really excited to be here talking with you all. For those of you who I haven't had the chance to meet yet, my name is Maeve, and I'm currently the Deputy Director with the National Rural Accountable Care Consortium, but I met many of you when I was working a couple years ago as the Flex Coordinator for Oregon, and before that I was at the Rural Health Research Center. So getting rural hospitals involved in population health and quality is one of my passions. So I'm really excited to be here with everybody and not only share about what we're seeing from a national perspective and some of the programs that have been able to support rural and moving into value-based pay, but also learning from you all what you're seeing on the ground in your state and what needs for resources you've heard from your constituents. Already, I think the results of the survey that you all passed on to your hospitals are very telling. We've had over 65 hospitals respond to that survey so far, which I think shows that there's a lot of appetite and a lot of curiosity about this topic, and that in terms of alignment with the Flex program as a whole, looking at financial health of hospitals, looking at quality provided in our rural hospitals, there's really strong alignment between the work that you're currently doing. So I'm excited about learning a little bit more about what's going on in your state so that we can best offer solutions to support the work underway. So here's an overview of what we're going to do over the next half hour. We want to make this learning collaborative as possible. I think Caleb was really intentional in calling it a collaborative rather than a webinar series or anything like that. One of the really exciting things about working with rural in the value-based pay arena is that this is new work, and you see innovative ideas popping up all over. So I want to encourage everybody to participate and discuss. There's an option to do that on Moodle, but I think being on a webinar is always more fun if you get a chance to talk. So we're going to warm up with some introductions in just a second here, but after we do that, we're going to go ahead and do just a brief overview of what value-based pay looks like for rural hospitals today, and talk about some next steps as well, and then discuss what we've learned so far on that survey assignment. So I want to start with a brief intro about National Rural, just so you kind of know where I'm coming from. We are a national nonprofit that works in 43 states, including places as far away as Hawaii and Alaska, but we're also working in Guam and the Virgin Islands. So we've seen a huge range of scenarios and also challenges, as well as opportunities and innovative solutions in rural value-based pay. So if you have a really tough situation in your state, I'd love to hear about it. Chances are we may have seen it somewhere else. our mission is really focused on partnering with practices across the country to facilitate implementation of innovative healthcare models. So we've helped practices get ready for all kinds of value-based pay options, whether it's looking at a comprehensive primary care plus program, an accountable care organization, bundled payment programs, Medicaid ACOs. We've done a lot of different work with different health systems, so I'm really excited about sharing some of those stories with you all as we go through the collaborative. And just to kind of give the 10,000-foot view of how our organization exists, we are funded through the CMS Innovation Center Transforming Clinical Practice Initiative. So we do a lot of direct work with practices as well as consulting and partnering with national agencies. So that's enough about me. I want to start by learning a little bit about what brought you all to the Learning Collaborative, including what made you interested in participating, learning if you have any work underway where you're specifically supporting value-based pay, and if there's anything in particular you're really hoping that we cover in this course, I'd love to hear about that too. So this is the fun part where it gets interactive. I mean, it's all fun, but I'm excited to hear from every one of you. If you look over in the left-hand side of the webinar module, we've got participants listed in alphabetical order, and I'm thinking the easiest way to do this is if we start with Daniel from Ohio and just work our way alphabetically down the list. If you can push *2 to unmute yourself and just share around these points, I'd love to hear from you all. So Daniel, I apologize, we're going to make you the guinea pig. Maybe we'll give you a prize at the end of the collaborative for this, but if you could start off our introductions, just talking about your interest in participation, any current work around value-based pay, and anything specific you're hoping to learn, that'd be great.
Yeah, happy to be the guinea pig. So basically the reason I joined this collaborative is to learn more about value-based pay. We really aren't doing anything too specific around it beyond what the cause in our state are doing with our vendor, and that's very limited. So mostly I'm here to learn more about it and what it is and how to implement it in my state.
Perfect, thank you. And I think you're in very good company there. On our polling questions, I think about 60% of folks said that they were neutral to not very knowledgeable about value-based pay, and then I think over 90% said they weren't sure of kind of what interventions we'd want to look at to support value-based pay. So you're in good company. All right, looks like Jack is next on the list.
This is Jack. Can you hear me?
Yeah.
This is Jack King in Montana. What made me interested in participating is I was invited, and I normally respond positively to invites for free education. So that was my initial reaction, and then certainly the work currently, and I like Daniel, I just need to learn a lot more about this. I'm relatively new to the Flex program, but not at all new to critical access hospitals, and I would just love to be able to not only participate in the conversations, but be able to contribute something. So if there's anything specific that I want to pull out of it, it would be that. But we do have a number of our larger critical access hospitals that are involved with the NRACO, and then we have a few others, the smaller ones that signed up for the consortium and the TCPI project. But I don't know a lot about how that's going or what they're doing. So I'm hoping to be able to be a sponge and learn a lot about this.
All right, wonderful, Jack. Glad to have you. You're definitely right on. There's a lot happening right now in Montana, so glad that you're with us. All right, Jada is next on the list.
Hi, everyone. This is Jada Lee from Mississippi. I'm the new Flex coordinator here, and I'm interested in participating participating just to learn a lot more about value-based pay. Some of our hospitals are actually, they're talking with, well, they're in talks to create an ACO, and I just want to be able to provide as much support as I can to them, and actually the establishment of it and just guiding them through the process. And with me being new, any opportunity for more education is welcome. So I thought I'd jump on this one.
All right, welcome, Jada. And Catherine from Wisconsin, you're next.
First, I'll make sure I'm unmuted.
Yes, there you go.
Excellent.
Good start.
Okay. I also have Kevin Jacobson. He's in the office next door online. I'll attempt to speak for both of us, but he can obviously feel free to add anything. I would say that this is probably my weakest area as a flex coordinator, so I'm really looking forward to the opportunity to learn more about value-based and the alternative models and so forth. We have two other very strong organizations that help rural hospitals in the state. The Rural Wisconsin Health Cooperative and our hospital association is very strong with rural. So I don't believe this is an area that's been left out by any means. I think those two organizations are very involved, but I feel like even if there's things going on and initiatives happening, that I need to be more informed and really stay on top of it more. So that's what I'm looking forward to.
Great. Thanks, Catherine. And anything to add, Kevin? I'm messing up the order. I skipped Kayla. All right, Kayla, I think you're in Kentucky, Kayla. I'm not sure if I got that right, but we'll go to you.
Right. Can you hear me?
Yes.
Okay, great. Yes, I'm in Kentucky. Got the invite and was tickled to participate. Much like Catherine said, I feel like this is one of my weakest points as a flex coordinator. It's something that I have, a little bit of knowledge on, but really not enough to be an effective, provider of technical assistance and stuff when it comes to this subject. So I was happy to participate. I know there's stuff going on in the state. We do have several of our critical access and then also some of our small rural that are part of an ACO. And I always ask them how that's going when I talk to them. The few that we have, but again, my knowledge is minimal on that subject. So I'm really just, here to learn with everyone else. I just want to be able to help my critical access hospitals when they have questions about this sort of stuff, and to be knowledgeable myself, and, when it comes to time to plan activities and to have conversations with the hospitals, I want to be as knowledgeable about it as I can. So I'm just really happy to be invited, and I'm looking forward to the project.
Great. Good to have you, Kayla. All right, Kevin, now it's your turn. And Kevin, if you're on, it's *2 to unmute yourself. And if you had to step away, I know it's lunchtime in Wisconsin, so that's totally fine too. All right. We will go ahead and go to the next name on the list, and I know I'm going to butcher this. Is it Laima?
Yes, this is Laima. You didn't butcher it. Hello?
All right.
Okay. I'm from Nevada, and I am a new flex coordinator and would like to learn more about transition to value-based payments. I feel like I have a grasp of how it works, but I need more in-depth understanding in order to be able to explain in detail to our cause. I feel like there's definitely a pushback for a lack of understanding. So that's why I'm here.
Great, welcome. All right, Lisa.
Hi, this is Lisa. Can you hear me?
Yep. Okay, great.
So what made you interested? I'll be like the others. I was thrilled to get an invitation, always looking for an opportunity to learn. And on this, you know, trying to understand what's going on in Georgia, I think I have like a 35,000-foot view of value-based payment models. And in our work, not only in our Flex program, working toward population health, but we have other initiatives in trying to stabilize the financial performance of our hospitals and patient-centered medical home. All of this just, to me, really aligns with our hospitals getting a more in-depth understanding about value-based pay and what their options are as far as getting into that. So work that's going on in our state, we have TCPI. Of course, we're having more and more rural ACO work that we keep hearing about, but again, not understanding exactly, you know, how they're making their choices, what led them to that, and then what specifically for those that have been in maybe a year or two now, what are their outcomes and how can we leverage that to help others in our state understand why this may be something they're interested in. So that's kind of what I'm helping to get out of it, is maybe the business case and a little bit more about how to understand how our hospitals could benefit from it.
Great. All right, thanks, Lisa. And Lynette from North Dakota. All right, and it's a *2 to unmute yourself if you're still on the line, Lynette. Oh, Lynette is typing in, so she might be having some tech difficulties. How about you, Melissa, over Missouri?
Well, I'm probably going to echo or repeat what everybody else pretty much has said. You know, I just really need to get a little bit of a better understanding of accountable care. And I know our hospital association, who's also on the line, delves into this much deeper than I do. So I just need to have a little bit more basic understanding so that I'm a little bit more educated whenever I can converse with them, because we do contract our Flex program to our hospital association.
Great. All right, Nancy Jo.
I would agree with pretty much what everybody else has already said. I have very little knowledge of anything to do with finance and cause, and so I'm very grateful for this opportunity. But I know we have some critical access hospitals working with ACOs, but I don't feel like I could sit in and intelligently contribute to a conversation about it. So I'm looking forward to coming out of this maybe a little smarter.
All right, wonderful. Glad to have you here. And Sherry?
Hi, I'm Sherry from Missouri, and I am new to the Flex program, so I welcomed the opportunity to receive the invite, and so I'm just trying to learn as much as I can.
Great, good to have you. Stephanie from Idaho.
Hi, I think I'm echoing what everyone else says. I think one of the things that may be a little bit different, so I do feel like I need to learn a lot when it comes to value-based purchasing, so I do think that there are so many nuances to it. But I also think, you know, we're working with one of our major insurers, and one of the things that she just said was, you know, that she was concerned about the threat to CAHs when it came to value-based contracting. So whenever you hear something like that from one of the major insurance carriers for the state, you realize, oh my goodness, there's so much to learn. And I better get ramped up pretty quick to be able to support them. So I think there's that. And, you know, we do have quite a few clinics that are involved in the TCPI initiative, clinics that are owned by critical access hospitals. And we have a couple of hospitals involved with the National Rural ACO. So again, like others, I asked them, how is that going? Some of the challenges with getting the data out, making sure their data is correct, that sort of thing. You know, so I try and kind of delve in wherever they need me, but I feel like I need a broader perspective and more in-depth knowledge about the overall idea behind everything regarding ACO and value-based.
Awesome. Good to have you, Stephanie. I'm curious, when you were talking with the major insurer, did she say specifically what she thought was going to be the threat from value-based pay to CAHs, or was she just kind of concerned in general?
This sort of came very timely, so this came up, this opportunity to participate in this group came up right around the same time that we got that email. So the next thing is to have that secondary conversation to kind of delve into what are those potential threats. I know some of the challenges right now are some of the hospitals that are taking advantage of some of those sort of broader initiatives that are you know, helping to reduce their readmissions. I think population health-based initiatives are affecting their bottom line. So I don't know if it has to do with something like that. But again, that's kind of our next step, is to engage her further to talk through that. And I was hoping that I could do this sort of concurrently so I can ask the right questions when I go into it.
Yeah, absolutely. All right. And last but not least, Stephen.
Hi, Stephen Jenga with the Missouri Hospital Association. And what made me interested in participating is I know there's a lot of commonalities in the group that is involved in this, dealing with the same hospitals or areas where we can all be able to share information that's working in some areas. So my interest in trying to gain some insights as far as the transition of this and how we can be able to better communicate this information to hospitals in Missouri. The work that is currently going on in Missouri as far as the value-based pay, a few pointers is a few critical access hospitals that are part of the FLEX program participate in the ACO. We do have and have seen models like the PCMH models. And at the same time, something that we did towards the end of last year at the Hospital Association is we sent a survey to all hospitals across the whole state, and one of the key things that we wanted to gain is to understand how they are performing on the key dimensions, and one of them was on the financial aspect of it, asking questions like, do you participate in any ACO or any value-based models out there? And so with that information, we looked at that, did major analysis in different ways, and the process we have right now is looking from a population health management standpoint, what are some of the tools and resources that were identified by the hospitals that can be used to help those hospitals close the gaps as we seek to learn more and more with other states or other organizations that are in the same field with us. So very exciting about that. And some of the other things that we've tried to educate critical access hospitals about is programs like the QHIP, which is through the Anthem, Blue Cross Blue Shield. And so trying to look at the landscape, because what is happening from CMS as far as the pay for performance for the other acute care hospitals, we know it's just a matter of time that that's going to catch up with the critical access hospitals. And the best we can do is to look on the horizon and see what's happening and how can we best position our hospitals to understand that if this comes from CMS, this is what the payers will be looking at, and to prepare them to be successful in the uncertain future as far as the pay for performance.
Great. And yeah, thank you, Stephen.
Thank you. And the last question, is there anything specific hoping to get out of this? And I think everybody, I echo everybody's word, is learning as much as possible, seeing what we can be able to communicate back to the hospitals to make sure that they are successful.
Perfect. Thank you. And it sounds like, Missouri, you've definitely done some more advanced work and kind of questioning your hospitals about this and some in-depth fact finding. So I'm excited to hear a little bit more about that as we go along in the collaborative. Thank you, everybody, for going through that. I know we had a lot of folks on the phone, but I liked the alignment in what I was hearing, and then some of the particular individual circumstances I think are really helpful to learn about as well. I'm interested to hear a little bit more about the what you're hearing from the commercial insurers, and then I think especially those of you in states where there's a lot of momentum around value-based pay, I'm really interested to learn a little bit more about how you all have been interacting with those TCPI participants. I wasn't going to specifically speak to what TCPI was, but I can definitely include that next week to give you a little bit more background on that program and what it does in the value-based pay, since it sounds like that's an interest. Also, just the appetite around kind of interacting and checking on your hospitals, seeing what the effect of value-based pay has been on them, I think is so valuable. You know, we all saw the NRHA newsletter that came out today, when did rural health become a healthcare desert? And I think value-based pay is really key to keeping a lot of our rural hospitals viable. In a lot of the preliminary results that we've seen in the survey, I saw a lot of hospitals were reporting non-participation in MIPS, which is a huge red flag in terms of financial sustainability for those Part D payments. So we'll talk about that a little bit later, but I wanted to start with a general overview of the Medicare value-based pay environment. It sounds like ACOs is the principal interest for a lot of states as far as looking at value-based pay. I'll go over a couple different models. Basically, for CAHs, ACOs are the only model that's available, more or less, but we'll talk a little bit more about that in a minute. And I think as flex coordinators and state offices of rural health, you have a really valuable role to play, because for any rural entity to participate in a value-based payment program, they have to have a certain number of covered lives or beneficiaries to be able to participate. So somebody in y'all's position where you can really act as the convener and bring that discussion about is hugely powerful. So let's talk a little bit about what the options are. Obviously, rural health is struggling right now from a financial sustainability perspective, and so we've got 70 rural hospitals closing since 2010. Over 600 are at risk for closure. And if you think of what the MIPS, or the Merit-Based Incentive Payment System, is doing right now, any hospital who didn't report in the past year for 2017 got a payment penalty, and with slim margins, that can really tip the scales. So making sure your hospitals are prepared to participate in value-based pay can be very important to their financial sustainability. So we'll talk about 4 models today. I know we only have 12 minutes left, but this PowerPoint is posted online. So Comprehensive Primary Care Plus, we'll talk about bundled payments. Both of these really aren't accessible to critical access hospitals, so we won't spend much time. And then we'll talk about the 2 options that most of the hospitals that are critical access or rural hospitals fall into, the MIPS program and the MSSP program. So you can kind of see that the quality payment program changed the landscape in a number of ways. First of all, RHCs and FQHCs are pretty much exempt from the quality payment program. But then there were 3 options for folks who were still involved. The Merit-Based Incentive Payment System, which gives a payment adjustment to hospitals based on performance in what was previously 3 categories of care, but is now 4 categories of care dimensions in 2018. A MIPS APM, which has elements of an alternative payment model, but isn't all the way risk-bearing, so you're still subject to MIPS reporting. So a lot of your Track 1 ACOs, which most rural hospitals active in an ACO, fall into this bucket. And then lastly, the alternative payment models, which are risk-bearing and include Comprehensive Primary Care Plus, bundled payments, and all of the other ACOs. And I'm seeing that a couple folks have to get off the call early, so I will definitely spend some more time talking about this on the next call. But the assignment for next time is just to encourage all of your practices to complete that survey that got sent out. So one of the big things for rural in terms of preserving viability is that the quality payment program is trying to push consumers to high-value care. They're going to be filtering more and more of these scores over to physician compare. And so, of course, if you have folks wanting to get information about the quality of care in their communities, the physicians will now be rated on this. Most rural hospitals are going to show up like Dr. Leslie Lane down here, where they're exempt, so there's just no data, which whenever there's no data, people tend to make up whatever stories are in their head, you know, what they heard from a friend or neighbor, which may or may not be representative of the quality care in their community. So being successful in value-based pay and being proactive is really important to preserving the reputation of rural health care. Moreover, it's a path to financial viability. For a lot of those clinicians who were just saying, you know, praise the Lord, I'm exempt because of the volume threshold from my merit-based incentive reporting, their payments are not going to be keeping pace with inflation, and that's another threat to rural health. We've also seen a tremendous increase in participation in ACOs over time. People who are in an ACO or other alternative payment model get preferential scoring under MIPS because of the way reporting is structured. So the more and more other people in the country advance and get more and more lives into alternative payment type models, if rural doesn't keep up, comparatively that quality of care is going to look worse. And we know that with the CMS Rural Health Strategy that was released 2 weeks ago, even though we've seen the current climate of CMS be a little bit more lenient towards rural health and a little bit more rural friendly, so to speak, there's still a huge push. This is a direct quote from that Rural Health Strategy on accountability and affordability, meaning we're going to be talking about quality, we're going to be talking about costs for rural health care. So one of the models is bundled payment models for hospitals. The big thing to know about this is it's not really a fit for critical access hospitals because they put a blanket payment down for given DRGs. You can select which DRGs you want to participate for, and you get to keep any savings after the bundled payment program. Again, doesn't make a lot of sense for CAHs because of cost-based reimbursement. We won't speak much about that. Comprehensive Primary Care Plus is limited to a few states. It is based in the primary care program. One thing that can be relevant for your hospitals, even though they're not participating as CPC Plus providers, is that sometimes participating in CPC Plus can prevent clinicians from participating in other value-based pay models, such as certain ACOs. So that's one thing to keep keep an eye out for. The other thing that's relevant to rural here, maybe not the hospitals, but RHCs and FQHCs cannot participate in this model. The idea of CPC Plus, though, is that you are getting a care management fee to provide wraparound care for your patients. It was supposed to be a multi-payer initiative, and I'm sure that, you know, Jack might have some insight into this as far as being involved on the Montana side of things, but a lot of CPC Plus rural practices that got into this because they thought it was going to be this great multi-payer initiative kind of got the short end of the stick because a lot of insurers, once they were in the CPC Plus program, thought that the rural providers weren't worth a special contract for CPC Plus. So this tended to be far less lucrative for practices, and with the amount of work that goes into this program, a lot of rurals had to leave the program because it just wasn't feasible without that added financial support. So if you were in a state that got CPC Plus, you might have had a lot of rurals who were in that program but are now looking for another value-based pay option because they were progressive but CPC Plus wasn't the right model. So that's put out, I think, some good partners for some of the hospitals to work with. And as far as what we're really looking at for options for the CAHs, there's two main options. So one is MIPS, or the Merit-Based Incentive Payment System, and this is a lot like your PQRS plus your meaningful use. And they've added in two new categories, one, clinical practice improvement, as well as cost. And so we asked about cost particularly in the survey, and we'll go over some results there. So MIPS is one option where you're reporting on all four of these categories, and we'll talk a little bit more about what each of these categories are. Secondly, a MIPS APM, which for most rurals this meant the Medicare Shared Savings or ACO program, is that second option. And this program is a little bit less of a burden for rurals because you don't do the clinical improvement activities reporting, and you don't have to worry about the cost portion of things because CMS is figuring if you're in an ACO, you're already kind of worried about the cost, and so we're not going to score you on it. You can just get your shared savings. So two options for most providers, again, are the MIPS or the MIPS APM for critical access hospitals. So for 2018, what your hospital should be worrying about right now is 1, quality. That's going to be 50% of their score in MIPS. 2, costs. That's going to be 10% of your score. 15, improvement activities, and this is the most flexible category. Probably a lot of the work that you're doing in the FLEX program, if they're participating, could support or could be enough for this area. We'll talk a little bit about that later in the program. And then finally, advancing care information, which is kind of like the new meaningful use, but this is performance-based. So instead of saying, you know, do you have a patient portal, yes or no, it's do you have a patient portal, what percent of your patients are using this patient portal, and then you're scored more on kind of a merit-based basis there. So these are the categories that your hospitals need to be worrying about in MIPS if they are not part of a MIPS APM. The idea with MIPS is that we're kind of having a Robin Hood situation, but maybe not in the way we'd like. This is curved grading, so I think all of the competitive pre-med folks that were always beating the curve and made it into med school are now in a situation where they're once again being graded in the curve. Practices can get up to 100 points under the MIPS program, and within those 4 categories, you get a certain number of points. Your score out of 100 is compared to how everybody else is doing. If you fall to the left side of the curve, you're getting a negative adjustment, and if you fall to the right side of the curve, you're getting a positive adjustment. So obviously, we want all of our rural providers to be getting this positive adjustment. And the unfortunate thing is that a lot of our rurals, in the survey, I think we had over 40% of rurals that responded to the survey saying they didn't report. You fall at the very bottom of this curve and can get negative adjustments of up to negative 9% on your Part B payments, which could be a huge detriment for those folks who are already operating on slimmer margins. So let's talk in depth about the Medicare Shared Savings Program. And again, we only have 2 minutes left, so we will spend more time on this next time. But this is a non-risk bearing program if you do track 1. If costs go up, you get shared savings. And if costs go down, there's no penalty. All of your existing reimbursement stays the same. So that's one of the most common questions that I get from hospitals is, and rural health clinics too, if I start participating in an ACO, are my reimbursements going to be docked? Is my cost-based methodology going away? And the answer is no, it's not. All of your existing reimbursement stays the same. So we only have 2 minutes left in the collaborative, and I think we've had some people who have to take off. This is, I think, a very important area to come to a common understanding on. So we're going to skip ahead and just talk a little bit about what we want to get done between now and next time, and then we'll cover a lot of this curriculum. We'll just move it to the next class since we had a busy time getting started today. But as far as the next steps go, we want to make sure that everybody fills out the survey, and I want to make sure everybody's had a chance to take a look at this. What we'll be doing in between now and the next class is sending you a little Excel sheet. Oops, I'm realizing that I'm not sharing my screen. Hopefully everybody's had a chance to take a look at the survey, and we'll be wanting to look at it by state so you can go ahead and see specifically what your program is showing. So hopefully everybody can see my screen right now. This is what the survey looks like if you haven't had a chance to take a look at it. And this will give you information about what you need to be doing with your states. I think there's kind of a twofold purpose here. You know, 1, do your states need help learning about APMs? Or 2, do your states need help with technical assistance within their APM? So this survey is going to give you a clue to that. So far with the results that we've seen so far, it's been really interesting, but I think there's a couple red flags that we want to make sure to address. Almost 25% of practices that responded to the survey out of the 65 that have filled it out so far have said that they have not started to develop a strategy for value-based pay. We had almost 40% of the hospitals who responded to this survey so far said that they did not report MIPS, which means that they are getting a negative adjustment to their payments as of 2019. And then finally, we had almost 40% again say that they had no plan to manage costs which is probably going to result in them getting a negative adjustment down the road. Lastly, again, almost 40% didn't have a specific plan to measure population health outcomes. So this shows that almost 40% of our rural hospitals that we've been able to get responses for so far don't have a plan. So this is what we're going to be attacking throughout the time in our learning collaborative. We'll be able to talk a little bit about where your states are. You'll be getting customized results for your states based on the survey going out. And we'll meet up next time to discuss the meaning of those results. The idea is that you'll leave this learning collaborative with kind of a template, one-page white paper, so to speak, that you can circulate throughout your state to help start coming up with a plan and start the conversation about what are you doing to band together to be able to attack value-based pay. So we are 1 minute past the hour, and I apologize for going a little over. There was just so much to fit in this time. We're going to be going over the APMs in a more thorough way next time, since we ran a little short on time this time. But before we close out the conversation today, are there any other questions or assignments or about assignments or next steps?
Yeah, I've got a quick one. This is Kayla in Kentucky. I think I joined like the whole thing late, so this is like the first time I've heard about the survey or anything. So just to clarify, I need to send that link to all of my critical access hospitals and tell them to have it completed by when?
If you can get them to complete it, I think by next Wednesday, that would be great.
Okay.
And I'll send you an email, or we'll get you an email with the survey, and we've got some draft language up there, and
oh, yeah,
everyone
that'd be great.
feel free to edit the language and make it as applicable to your critical access hospitals as you can. And we've heard back from a few people like, well, this sounds funny, but if I word it this way, that would be much more accepted from my hospitals, and that is absolutely what we want you guys to do. You know your hospitals more than we do. We just wanted to send you a little something as a draft. So yeah, please feel free to edit the language and have it come from you if however is best.
Caleb, have you already sent that out?
I have not sent. I may not have sent yours, but I
okay.
can.
If you could, yeah, if you send that, I'll get that out today.
Absolutely.
Thanks.
All right, wonderful. Any last questions before we wrap up? No? All right. Caleb, is there anything else that you wanted to add before we closed out for the day?
Not that I know of. So we will meet again next week on the 7th, and I have it at 1 p.m. on my calendar. So depending on where you are, that'll correspond